Good morning, everyone, and thank you, SAGES, for the opportunity to present our work. I'm Amanda Belluzzi, a current research collaborator at Mayo Clinic and an attending at Rovigo Hospital in Italy. Today, we present the multicenter analysis of internal hernia after BPDS and SAGES. We have no disclosures. First of all, we have to give a definition of internal hernia. Internal hernia is a protrusion of abdominal viscera, most commonly bowel loops, through a peritoneal or mesenteric opening into a compartment in the abdominal and pelvic cavity. BPDS, that is to say, biliopancreatic diversion with duodenal switch and single anastomosis duodenilostomy with sleeve, have been associated with excellent and sustained weight loss outcomes among the most commonly performed bariatric procedures. The reported incidence of internal hernia after BPDS varies from 0.4 to 18% of cases. We have to point out that in SAGES, as you can see from the picture, there is no need for intestinal transection, avoiding further opening of the mesentery. This may decrease the risk of internal hernia compared to BPDS. Here, as you can see from the figure, there are all the possible sites of herniation after metabolic and bariatric surgery, that is, intermesenteric defects, Pedersen space, transmesocolic defect, and space of Parrot or interduodenal defect. We have to point out that Peterson's original description of the hernia is widely different from the modern description of Pedersen hernia in current literature. Dr. Peterson originally described hernia involving loop gastroileal anastomosis, and his description requires an efferent limb to herniate behind the anastomosis. That is why we call it retroanastomotic. As you can see here, we see the boundaries of the retroanastomotic location of original Pedersen hernia, while in the second figure, we see the boundaries of the modern description of Pedersen defect that we usually refer to pseudo-Pedersen, where the herniation is not located behind the anastomosis. As you can see here, we see the mesenteric defect, the pseudo-Pedersen defect, the closure of pseudo-Pedersen defect, and the closure of mesenteric defect. Our study is a multicenter retrospective review of patients who underwent BPDS and SAGES between 2008 and 2023. We collected all the data regarding baseline characteristics, comorbidities, operative characteristics, postoperative outcomes, weight loss outcomes in terms of total weight loss percentage, and rate and site of internal hernia. With a total of more than 1,100 patients with a mean follow-up of 1.7 years, the overall incidence of internal hernia was 1.12% in cases. Most cases of internal hernia occurred in the first 24 postoperative months. The only case of internal hernia detected in the SAGES group was at the pseudo-Pedersen space. We have to say that all cases were surgically managed with hernia reduction and mesenteric defect closure with no further surgical intervention. As you can see from the first table, we collected all patient demographics and their characteristics, and we need to point out one aspect, that there was not a statistically significant difference between two groups in terms of patient demographic, obesity-related medical conditions, and operative characteristics in terms of operative time and length of stay. In the second table, we can see the internal hernia characteristics. The most common site of internal hernia and the most common site in both groups was a pseudo-Pedersen space. The most common presenting symptom was abdominal pain followed by GI bleeding, and the most commonly adopted diagnostic method was CT scan. In conclusion, internal hernia after BPDS and SAGES is a well-known and underreported complication in literature. Closure of mesenteric defect, when possible, although recommended, is not a definitive solution since after weight loss, the opening can be even bigger, and so it's not so easy to get by. Regardless of imaging results, if there is a high clinical suspicion of internal hernia and bowel obstruction, a diagnostic laparoscopy is indicated, and if the internal hernia is confirmed, reduction must be followed by a mesenteric defect closure. Thank you for the attention.